Good evening and warm greetings to everyone joining us today. On behalf of the entire VIAMS team, I extended a heartfelt welcome to each one of you to today's webinar on integrated neurorehabilitation, how Ayurveda, physiotherapy, ASLP, and mind-body practices work together. I am Nandana, Digital Coordinator at VIAMS, and it's my pleasure to serve as your host for today's session. Neurological conditions such as stroke, Parkinson's disease, neuropathies, and other chronic disorders do not affect just one system of the body. They influence movement, balance, coordination, speech, swallowing, cognition, emotional well-being, and even a person's confidence and independence. Because of this complexity, neurorehabilitation cannot be one-dimensional. Medication are not enough. Isolated therapy approaches may give partial benefit. What truly makes rehabilitation effective is integration, where multiple disciplines work together with a shared goal, restoring function, improving quality of life, and supporting long-term recovery. At VIAMS, we believe that healing happens best when systems complement each other. Our integrated neurorehabilitation model combines Ayurveda and Panchakarma to address systemic imbalance, improve circulation, reduce inflammation, enhance neuromuscular response, and support tissue nourishment. Physiotherapy to improve motor control, strength, balance, gait, and functional independence through evidence-based neurorehabilitation techniques. ASLP to address speech clarity, voice allowing difficulties, and communication challenges that significantly impact daily life. Mind-body practices including yoga, breath work, psychological support, and lifestyle modification to enhance neuroplasticity, emotional resilience, cognitive stability, and overall well-being. Rather than functional separately, these departments collaborate closely. Each patient's treatment plan is individualized based on disease stage, physical capacity, cognitive status, and psychological needs. This coordinated approach ensures that therapies do not overlap unnecessarily, but instead reinforce each other for better outcomes. Today's session is designed not only for healthcare professionals, but also for patients and caregivers who wish to understand how a truly integrated model can transform rehabilitation outcomes. It now gives me great pleasure to introduce our distinguished panel of speakers. Dr. Vijit KV, Managing Director and Chief Physician of VIAMS. Dr. Needu Yasjit, Medical Superintendent at VIAMS. Dr. Prasad AP, Chief Physiotherapist. Dr. Anuj CD, Clinical Psychologist. Dr. Aruna KP, Specialist in Naturopathy and Dietetics. MS Dilna Sultana, Speech Therapist. Each of them represents a vital pillar of our integrated neurorehabilitation model. Without further delay, I respectfully invite Dr. Vijit KV, Chief Physician and Managing Director of VIAMS, to deliver the introductory address and share his insights on how integration forms the foundation of effective neurorehabilitation. Doctor, over to you.
Good evening, all. Thank you, Nandana, for the wonderful introduction. I hope I'm audible to you, correct?
Yes.
Thank you. So, it's a privilege to be a part of this discussion on integrative neurorehabilitation. When we talk about any neurorehabilitation, especially the Parkinson's disease neurorehabilitation today, we are no longer talking only about tremor or dopamine deficiency. We are talking about a long-term neurofunctional journey that affects the movement, communication, emotional stability, sleep, and independence. So my focus today is to share how an integrated model combining Ayurveda therapies, Panchakarma treatments, rehabilitation sciences, and mind-body approaches can support patients across this long journey. So, not just medically, but functionally and humanly. Why Parkinson's needs an integrated care? So, Parkinson's disease is a progressive, multi-system, and functionally complex early in the disease. Patients compensate very well, but as years progress, multiple domains begin to get affected simultaneously. Movement becomes slower, speech softer, swallowing effortful, sleep fragmented, and emotional resilience fragile. When we treat only one dimension, we often miss the whole patient experience. So, integrated care allows us to address motor, non motor, metabolic, psychological, and functional adaptation together. Let's we had already discussed what Parkinson disease in last few months webinar, but like in short, in one line, from a neurological standpoint, Parkinson disease involves degeneration of dopaminergic neurons, particularly affecting basal ganglia, motor circuits. But clinically, Parkinson's is more than circuitry failure. Patients often describe it as my body is not responding the way it is used to. Reaction becomes slow, expression reduces, spontaneity fades. So the Parkinson's must be approached as both neurochemical and functional system disorder. So a global burden. Why Parkinson's is considered as a global burden? So globally, Parkinson's disease is increasing rapidly, mainly due to aging populations. But unlike many other chronic diseases, Parkinson's create long duration disability. Many patients live 15 to 25 years after diagnosis. This makes long-term functional preservation extremely important, not just for patients, but for families and healthcare systems. So let us see the impact on quality of life. When we speak to patients, their biggest fears are rarely tremor. They worry about losing independence, losing their voice, losing their ability to eat safely, losing confidence in social settings. Integrated neurorehabilitation directly address these fears by focusing on function preservation and confidence maintenance. Let's see the motor symptoms we discussed earlier, but the motor symptoms are what usually bring patients to medical attention. Tremor, rigidity, slowness, and imbalance, instability gradually interfere with daily tasks. But if we only treat visible tremor symptoms, when we often miss the hidden disability building underneath. So, tremor, bradykinesia, rigidity, postural instability, functional impact are the symptom presence. See, the non-motor symptoms are often more disabling. Sleep disorders reduces recovery capacity. Depression reduces therapy participation. Constipation alters medication response. Autonomic dysfunction affects blood pressure stability. These need equal attention, management, planning. So the early subtle changes, the signs or symptoms will be the early Parkinson signs are often subtle. Small handwriting, reduced arm swing, softer the voice, reduced facial expression, loss of smell. If we identify patients at this stage and start an integrative care, long-term outcomes can be significantly influenced. Let us discuss about the disease progression pattern. So the individual disease trajectories or the compensation, that is a decline transition, the non-motor dominance later stages. So the Parkinson progression is not identical in all patients. I repeat, Parkinson progression is not identical in all patients. Some progresses very slowly, some become faster, and some develop early cognitive or non-motor dominance. This variability is why personalized neurorehabilitation is essential. Let us see the prognosis perspective of Parkinson's disease neurorehabilitation. So today the prognosis discussions are evolving. Earlier we focused on disease survival. Now we focus on functional survival. How long can patients walk safely, speak clearly, eat independently, maintain emotional stability? These are meaningful clinical outcomes. So the functional prognosis, the early rehab importance, and quality of living the focus. Now, let us see the Ayurvedic perspective of Kambavada. So in Ayurveda, a Parkinson's disease or a Parkinson's symptom complexes are described under Kambavada. Kamba means tremor and Vada means neurological problems. So this reflects aggravated Vada affecting neuromuscular coordination and movement stability. So deeper tissue involvement is understood as Majja Dhatu impairment. So Ayurveda traditionally focuses on slowing functional deterioration and preserving physiological harmony. So Vada dysregulation, movement instability, Majja Dhatu involvement, and functional preservation focus is the concept of the Ayurvedic perspective of Kambavada. And in Basavarajiya, the Kambavada is defined as Karabada Tale Kambe, Deha Brahmana Dukkide, Nidra Bango Madikshina, Kambavadasya Lakshana. So the bridging neurology and Ayurveda. So the neurodegeneration, Dhadukshaya. Neurotransmitter imbalance, Vada dysregulation. Network failure, systemic functional imbalance. So if we translate this Ayurvedic concept into modern clinical parallels, Dhatu depletion resembles the tissue degeneration. So the Vada dysregulation resembles signaling instability, and system imbalance resembles network dysfunction. These bridges allow scientific integrative communication. So why integrated neurorehabilitation? Parkinson's disease or any chronic degenerative or neuroparenchymal or neuropsychiatric disease is not only a neurotransmitter deficiency. It is motor learning disorder, sensory processing disorder, emotional regulation disorder, and metabolic adaptation disorder. Therefore, multi-domain therapy is very essential for the successful neurorehabilitation. So the chemical plus functional disorder, multi-domain therapy need and rehab central role. Let us speak about our VIAMS integrated treatment protocol. So our integrated protocol uses a synchronized therapy domains. Ayurvedic medicine support the internal metabolic and neurosupportive balance. Panchakarma supports systemic detox and regulation. Physiotherapy supports motor learning and neuroplasticity. Dr. Prasad will be detailing that in the next coming sessions. ASLP preserves communication and swallowing. Mind-body therapy support autonomic balance. Psychological helps coping. Nutrition support metabolic resilience. So this each and every department will be handled by the specialist in the coming session. So the patient-centric customization or the importance of patient-centric customization. Every Parkinson patient is different, as I mentioned earlier. Some are tremor predominant, some are gait dominant. That means bradykinesia will be there, echinacea will be there, hand swings will be very slow, postural disability will be there, turning difficulty will be there. Some are non-motor dominant. Constipation will be dominant in people with the Parkinson disease. Somebody have disturbed sleep, fearful dreams, hallucinations, bruxism, high tension, anxiety, emotions, high stress. Stress are of different types, acute, chronic, and perfectionist stress that are motor dominant. Then the therapy must adapt continuously to patient stage and symptom dominance. So the key points are the precision neuro rehab, the goal-based therapy, and caregiver integration. So long-term functional outcomes in neuro rehabilitation. The realistic goal is functional preservation and slower the decline. So better independence duration is very important in the neurorehabilitation. So reduced has hospitalization risk, hospitalization risk, better emotion well-being for both patient and caregiver. Here, the caregiver have the very important role in any type of neurorehabilitation, especially in people with Parkinson's disease. Why? Because the patient will be having different motor, cognitive, and sensory even in day or night. The only person for giving this care is the caregiver, maybe a spouse or maybe an external caregiver. So the role of the caregiver is very important in neuro rehabilitation. So independence preservation, caregiver quality of life is also very important in neuro rehabilitation. Then sustainable disease adaptation. So neuroplasticity support concept. So the average time of a neuroplasticity is minimum 21 days of time. So the brain retains adaptive plasticity, movement repetition, sensory stimulation, metabolic optimization, then mind-body regulation, all support functional and neural compensation. So the main key points of this neuroplasticity support is the movement learning, sensory input importance, and brain adaptation capacity. So I'm just getting the first session of this webinar. So I will the closing thought of the first session is Parkinson's care is not only about slowing the disease. It is about preserving life participation. Integrated neurorehabilitation allows us to support patients not just medically, but meaningfully too. So the key points of the closing thoughts are preserve identity, preserve communication, preserve dignity. Yes, we can control Parkinson's disease. By this, I would like to invite Dr. Needu Esjit to the role of Panchakarma in neurorehabilitation. Over to you, Doctor.
Namaste, everyone. Thank you all for taking the time to join this session. Neurological disorders do not affect only the body. They affect a person's independence, emotions, confidence, and even their identity. When someone who was active and independent suddenly struggles to walk, speak clearly, or remember familiar names, it deeply impacts not only the patient, but also their entire family. Recovery from neurological illness is often slow and challenging. But today, I would like to share how Ayurveda understands these conditions and how Panchakarma can support recovery and rehabilitation in a holistic and meaningful way. Let us first understand the nervous system in a simple way. Think of your body as a complex electrical system. The brain is the main control center. The spinal cord is like the main cable, and the nerves are like wires that carry signals to every part of the body. This system controls movement, sensation, speech, memory, balance, and coordination. When the system gets disturbed, the person may experience walking difficulty, tremors, weakness, loss of balance, slurred speech, memory problems, stiffness, or paralysis. These are broadly known as neurological disorders. According to Ayurveda, the nervous system is primarily governed by Vata dosha. Vata is the principle of movement in the body. It controls nerve impulses, circulation, breathing, muscle movement, thinking, and mental activity. Whenever Vata becomes imbalanced, the nervous system is usually the first to suffer. Ayurveda describes more than 80 conditions caused by aggravated vata called vata vyadhis. Conditions like stroke, Parkinson's disease, Alzheimer's disease, multiple sclerosis, and peripheral neuropathy can be understood under this category. This shows us that Ayurveda had deep insight into neurological disorders long before modern classifications existed. Now, the important question is, why do neurological disorders occur? Ayurveda explains two main reasons. The first is dhatu kshaya, which means degeneration of body tissues. Among the 7 body tissues described in Ayurveda, the most important for nerve health are Majja dhatu, Asti dhatu, and Mamsa dhatu. When digestion is weak for a long time, when nutrition is poor, when there is chronic stress or lack of sleep, or due to aging, these tissues do not get proper nourishment. Slowly, degeneration begins. This can lead to weakened nerves, poor signal transmission, memory decline, and movement problems, similar to what we see in Parkinson's disease or Alzheimer's disease. The second cause is Margavarana, which means the obstruction of pathways. Vata needs free movement in the body, but its pathways may get blocked by toxic waste called ama, by blood clots, or by excess fat. When digestion is weak and lifestyle is sedentary, toxins accumulate and block circulation. For example, in stroke, a blood clot blocks blood flow to the brain. Oxygen and nutrients do not reach the tissue, leading to paralysis. Ayurveda explains this is as obstruction-related vata disorder. So in simple words, either tissue degenerate or pathways get blocked, vata become disturbed. Now, let us understand the connection between digestion and nerve health. That is the flow of pathogenesis. Ayurveda says everything begins with Agni, that is our digestive fire. When Agni becomes weak, food is not properly digested. This produces ama that blocks the body channel. When channels are blocked, tissues do not receive nourishment. So over time, ojas means the vital essence responsible for our immunity and strength, that becomes depleted. When ojas is low and channels are blocked, vata becomes unstable. This ultimately leads to neurological disorders. So digestion, immunity, and nervous system health are deeply interconnected. Coming to treatment philosophy, Ayurveda does not simply suppresses the symptoms. It asks deeper questions like, why did Ayurveda become aggravated? Sorry, why did Vata become aggravated? Why did tissues degenerate? Why did immunity weaken? So the treatment focuses on correcting digestion, clearing toxins, nourishing tissues, strengthening ojas, and stabilizing Vata. So let us discuss the important part, the role of Panchakarma in neurorehabilitation. Panchakarma is not just a detox. It is a systematic process of cleansing and rejuvenation. It removes deep toxins, enhances the effectiveness of medicines, nourishes nerves, calm aggravated vata, and improves the body's natural healing capacity. Panchakarma is carried out into 3 structured stages. And the first stage is Purva Karma, which means the preparation stage. The main objective of this stage is to prepare the body by strengthening digestion and initiating the process of toxin elimination. Before any major cleansing therapy is performed, it is essential to ensure that the digestive system is functionally properly and that the body is ready to respond positively to treatment. This phase includes procedures such as Deepana and Pachana, which stimulate and regulate the digestive fire, and Snehana, involving internal and external elimination to loosen deeply seated toxins. Abhyanga, a therapeutic medicated oil massage, and Svetana, that is therapeutic sweating. In this, we use different types of kiri therapies such as Navadhanya kiri, Elakiri, etc., which help improve circulation, reduce stiffness, and mobilize accumulated toxins from the tissues. Clinically, these therapies enhance blood flow to the nerves, reduce muscle tightness, improve flexibility, and facilitate motor relearning. Most importantly, Purva Karma prepares the body not only for the main Panchakarma procedure but also enhances the effectiveness of physiotherapy by creating a relaxed, flexible, and receptive internal environment for rehabilitation. So now let us understand the second and most important phase of Panchakarma, that is Pradhana Karma. The objective of this phase is to directly address aggravated vata, which plays a central role in most neurological disorders, and to actively support neurological recovery. At this stage, therapies are carefully selected based on the patient's condition, strength, stage of illness, and overall health status. In certain cases, cleansing procedures such as Vamana or Virejana may be advised to eliminate deeply accumulated toxins and clear systemic imbalances. However, in neurological conditions, the most significant therapy is Vasti Chikitsa, which is considered as the cornerstone treatment of Vata disorder. Vasti Chikitsa works at the deep level. It pacifies aggravated Vata, nourishes the nervous system, strengthens tissues, and support improvement in both sensory and motor functions. Nasya, the administration of medicated oil or herbal preparations through the nasal route, that is directly influences the head and the brain region, and it helps stimulate brain function, enhance cognitive abilities, improve speech clarity, support memory, and restore facial muscle control in conditions such as facial palsy or stroke recovery. Also with this, therapies such as Shirodhara, Takradhara, Talapodichil, Talam, Piju primarily act on the mind and higher nervous centers. They calm the nervous system, improve sleep quality, reduce anxiety and depression, and promote emotional stabilities. Together, these therapies work not only at the physical level but also support emotional and mental stability, making them highly valuable in neurorehabilitation. So now let us move to the third stage of Panchakarma, known as Pachat Karma or Samsarjana Karma, which focuses on dietary care or gradual restoration. After the main cleansing therapies, our body becomes more receptive but also more sensitive. Therefore, proper diet regulation is extremely important at this stage. The objective here is to restore strength, rebuild digestion, and prevent recurrence of disease. Patients are advised to take warm, light, and easily digestible foods that do not burden the digestive system. And simple preparations like rice gruel, lentil soups, and well-cooked vegetables help proper digestion and nourish the tissue gently. So in simple words, the essence of Ayurvedic neurorehabilitation is correct our Agni, remove Ama, pacify Vata, nourishes and enhance our ojas. So now let us see how Ayurveda works along with physiotherapy. Neurological disorders require long-term structured rehabilitation. The goal is to improve walking, balance, speech, coordination, and overall independence while also preventing complications like stiffness and muscle weakness. Panchakarma supports this recovery by nourishing the nerves, reducing stiffness and spasticity, improving circulation, and calming the nervous system. When the body becomes more relaxed and flexible, physiotherapy exercise can be performed more effectively, leading to better progress. Coming to physiotherapy, it restrains the body through guided exercises, balance training, gait training, and muscle re-education. It helps the nervous system relearn functional movements and regain strength. When Ayurveda prepares the body internally and physiotherapy retrains it externally, together they create a powerful and complementary approach to recovery. Thank you all for your time and valuable participation. With that, I now invite our physiotherapist, Dr. Prasad AP, to share his insights on the physiotherapy approach to neurorehabilitation. Doctor, over to you.
Am I audible?
Yes.
Yes.
Hi, everyone. Good
Hi.
evening. I'm Dr. Prasad, physiotherapist at VIAMS, and I have been working with Team VIAMS for more than 12 years. And I'm really excited to share some insights into how we approach Parkinson's disease cases. So please feel free to drop your questions in the chat anytime during the session, and I would like to keep this as interactive and engaging as possible. So, in my practice, I have seen how Parkinson's can slowly make people feel like they are losing control over their own body and daily life. And that can be incredibly frustrating and even frightening, not just for the person living with Parkinson's, but for their loved ones as well. But along this journey, I have also witnessed something truly powerful. I have seen how the right movement strategies, consistent rehabilitation, and the remarkable ability of the brain to adapt, what we call neuroplasticity, can help people regain confidence, function, and hope. Over the next few minutes, I invite you to look beyond the diagnosis. Let's focus instead on the possibilities, the practical strategies, and the small but meaningful steps that can help you or your loved ones maintain independence, dignity, and better quality of life. So, let me begin by giving a brief understanding of Parkinson's disease. As Dr. Vijit said, Parkinson's disease is a chronic progressive condition that affects the nervous system. Most people recognize it through its key movement related features such as stiffness or rigidity, slowness of the movement known as bradykinesia, tremors, and problems with balance and posture. However, Parkinson's goes far beyond movement alone. It can influence the way a person walks, speaks, swallows, thinks, and even feels. Many individuals also experience sensory changes, behavioral and cognitive challenges, disturbances in digestion, and changes in heart and lung function. So, Parkinson's disease is a neurodegenerative disorder affecting both men and women, and it is most often seen in people above age of 40. But Parkinson's doesn't always wait for old age. In some individuals, symptoms begin much earlier, before the age of 40, a condition known as young onset Parkinson's disease. For many of these individuals, the diagnosis can be unexpected and life changing as it arrives during a phase of life filled with responsibilities, ambitions, and family commitments. So let us classify Parkinsonism. Uh, the term Parkinsonism refers to a group of disorders characterized by basal ganglia dysfunction, producing the cardinal features, as we said, bradykinesia, rigidity, tremor, postural instability. And we can classify the term Parkinson's into like idiopathic Parkinson's disease, secondary Parkinsonism, Parkinson's plus syndrome. We generally tell Parkinson's disease, PD, but we have certain classification for the Parkinson's disease. The first one is idiopathic Parkinson's disease. This is also called as the primary Parkinsonism, and this is the most common form, accounting for approximately 75 to 80% of all cases. As the term suggests, idiopathic, the exact cause is unknown. This idiopathic Parkinson's can be further classified based on age of onset, like juvenile Parkinson's disease. In juvenile Parkinson's disease, the onset before 20 years of age, that the symptoms develop before 20 years of age. And it is very rare and often genetic in origin. Then comes young onset Parkinson's disease. Here, the onset between 21 to 40 years of age, and they may have a familial tendency too. These conditions, the slower disease progression compared to the late onset. Then comes early onset Parkinson's disease, where the onset before 40 years of age, higher likelihood of genetic association. Then comes the late onset Parkinson's disease, that is onset after 40 years of age, most common presentation, typically non-familial. Then comes the secondary Parkinsonism. This occurs due to identifiable causes, like common causes include as drug-induced, the people who consume like antipsychotics or antiemetics, dopamine blocking drugs consumed for a long term. This may cause to secondary development of secondary Parkinsonism. Then comes toxin exposures like industrial chemicals, carbon monoxide, manganese, pesticides. This all comes under this. Then comes post-infectious, like viral encephalitis. Those who have any viral encephalitis infection, they may have this secondary Parkinson's disease. Then comes metabolic causes like hypothyroidism, hypoparathyroidism, calcium metabolism disorders, etc., etc. So much of that. Then comes structural causes like brain tumors, strokes affecting the basal ganglia, head injury, and all. Then comes the last one, Parkinson's plus syndrome. It's also known as atypical Parkinsonism. These are neurodegenerative disorders where Parkinsonism features are present along with additional neurological signs like progressive supranuclear palsy, that is PSP, multiple system atrophy, normal pressure hydrocephalus, corticobasal degeneration, etc. Let's come to the main part, the rehabilitation. So rehabilitation in Parkinson's disease, what we do here at VIAMS. So rehabilitation plays a crucial role in the management of Parkinson's disease. So rehabilitation focuses on reducing functional limitations, promoting independence, and improving quality of life. What are the goals of rehabilitation? The primary goals of rehabilitation is to improve mobility and gait. Gait is nothing but the way the patient walks. Enhance balance and reduce falls. Maintain strength and flexibility, to improve posture and functional skills, to support communication and swallowing, promote participation in daily activities. Rehabilitation also helps prevent complications such as deconditioning, contractures, respiratory issues, and depression. So at VIAMS, we have a multidisciplinary team for this rehabilitation. So effective management requires a good team approach, like physicians for medical management, physiotherapists for mobility, balance, strength, and training, speech language pathologists for speech and swallowing management, psychologists for cognitive and emotional support also. So after a detailed assessment, a patient-centered rehabilitation plan is developed based on disease stage, functional limitations, patient goals, and environmental and family factors. So rehabilitation should be continuous, goal-directed, and regularly reassessed. So what we assess in Parkinson's disease, what we physiotherapists assess in Parkinson's disease. In patients with Parkinson's disease, the assessment includes musculoskeletal functions, motor functions, autonomic functions, and cardiorespiratory functions. So in musculoskeletal assessment, we look for flexibility, especially the joint range of motion of the spine is very important. So we check for the joint range of motion, not only of the spine, but also all other joints as well. Then comes posture. We check for the posture, whether the patient is stooped posture or whether they have any increased thoracic kyphosis and all. Then comes the muscle performance. In muscle performance, we look for strength and endurance of the muscles. Then comes motor function assessment. So we look for rigidity, bradykinesia, and tremor. In rigidity, we have to assess for whether the rigidity is lead pipe rigidity or cogwheel rigidity. Then comes bradykinesia. Initially, the slowness of movement will be there in initial cases and may progress to akinesia. Akinesia is there will be no movement at all in later stages. So we have to look for that. And then comes tremor. We need to see the location and severity of the tremor, whether it is resting tremor or action tremor. And then comes postural instability. We have to check for both static balance as well as dynamic balance. Then comes gait analysis. That is the way the patient walk. So we need to check for whether the patient is having shuffling gait or with reduced arm swing, reduced trunk rotation, difficulty in initiating gait, fascinating gait, reduced foot clearance. We have to assess their gait properly. Then comes autonomic assessment. Autonomic assessment, we check for their drooling of saliva from the mouth. Then comes excessive sweating. Then comes orthostatic hypotension or postural hypotension is a sudden drop of BP, that is blood pressure, that occurs due to a sudden change of bodily positions, like from lying to sitting, sitting to standing, and also we have to check, monitor their BP continuously and look for this orthostatic hypotension. Then comes cardiorespiratory assessment. We need to check their heart rate, as I said, blood pressure, respiratory rate, chest wall mobility, thoracic expansion, and all. So this comprehensive assessment helps in planning a individualized rehabilitation program based on patients' deficits and functional limitations. So after detailed assessment, patient can be functionally divided into 4 stages. So the first one is early stage. In early stages, the patient will be like fully independent, and they may have unilateral tremor or rigidity and may have minimal functional limitations. So in this stage, the physiotherapy management focus is mainly preventive, which so what we give is flexibility exercises to maintain joint mobility, postural correction to prevent stooping posture, aerobic exercises to improve endurance, and education regarding posture, activity, and exercise compliance. And our goal is to maintain normal function and delay secondary complications. Then comes the early middle stage, the second one. In this, the patient may have bilateral bradykinesia and rigidity. They may have mild speech impairment, minimal gait disturbances, and may develop stoop posture. So this stage requires corrective exercises. So we need to focus on postural correction exercises, strengthening of the extensor muscles, then gait training with cueing techniques, balance training, breathing exercises if needed. So here our goal is to improve quality, movement quality, and prevent worsening of posture and gait abnormalities. Then comes the third stage, that is called late middle stage. Here the clinical features will be like the symptoms will be more pronounced, balance problems present. They may be independent in their activities of daily life, but may require minimal assistance. So both corrective and compensatory strategies of treatments are required. So we, with advanced balance training, fall prevention strategies, functional task training, and assistive devices like walking sticks and all, if needed, we suggest in this stage. So we have to maintain independence and ensure safety during mobility at this stage. Then comes the last stage, that is the fourth stage, is called late stage. Here, the clinical features will be like the patient may have severe disability, they will be dependent in their activities of daily life, they may have marked postural instability also. So, physiotherapy management, what we focus is to shift mainly to compensatory and supportive care. We need to give compensatory and supportive care. So, our goal is to prevent contractures. So we continuously change the position of the patient to prevent contractures, passive movements, pulmonary care and breathing exercises, skin care and pressure sore prevention, caregiver education, and assistance with hygiene and daily care. These prevent complications and improve comfort and quality of life. So this stage-based rehabilitation approach helps physiotherapists to modify treatment according to the functional capacity and disease severity of the patient. So a combined approach of this pharmacological management and physiotherapy is essential for optimal outcome. So physiotherapy enhances functional mobility and participation too. So what we do, physiotherapists do, like what are the interventions? So the interventions can be categorized, like physiotherapy interventions can be categorized into motor learning strategies, exercise training, balance training, locomotor training, also called gait training, and cardiopulmonary training. So let's talk about motor learning strategies. Motor learning focuses on improving movement initiation and execution by breaking long and complex movements into smaller components, avoid dual tasking to improve movement quality, and use repetition and task-specific practice. Like, for example, like visual cueing using floor markings placed perpendicular to the gait pathway of the patient, walking over colored lines to improve step length, then stepping over small height hurdles to improve dynamic weight transfer, etc. So this will help to improve their bradykinesia, which reduce freezing also and enhance motor control. Then comes exercise training, the second one. So exercise training includes relaxation, flexibility, strengthening, and functional training. So in relaxation exercises includes gentle rocking movements on vestibular ball or therapy ball, slow rhythmic rotational trunk and limb movements, breathing exercises, and gentle yoga can also be performed. This will reduce rigidity and improve movement fluidity. Then comes flexibility exercises. Like flexibility exercises, like active and passive range of motion exercises. Like we focuses on stretching of the shortened flexor muscles and strengthening of elongated extensor muscles. Then passive positioning techniques like prone lying to reduce flexion contractures, which improve posture and prevent contracture. Then comes strength training. So this strength training is indicated especially in mild to moderate stages, which focuses on extensor muscles especially, and can be done with dumbbells, resistance bands, etc., which improves gait, balance, mobility, and reduce fall risk and enhances the quality of life. Then comes functional training. Focus on improving daily mobility tasks. We train bed mobility like rolling, supines to sit to stand training, sitting balance on therapy ball, standing weight shift, trunk rotation, reciprocal arm swinging, steps ups on low platform, then wall or corner push-ups, which improve their independence in mobility and ADMs. That is activities of daily life. Then comes balance training. So in balance training, postural instability is common in later stages of Parkinson's studies. So we start with static and dynamic balance exercises, weight shifting activities, reaching task, axial trunk and head rotation exercises, therapy ball sitting exercises, single leg standing also can be added if safe, which improve postural correction and reduce fall risk. Then comes locomotor training. That is very important. That is the gait training. So gait training, that is the walking pattern, it impairments include slow speed shuffling, reduced arm swing, and stoop posture are the main impairments in gait. So which can be corrected by treadmill training with overhead hardness, brisk marching practice, walking on floor footprints, arm swing training, postural correction during walking. Our goal is to improve the step length, walking speed, and gait symmetry. Then comes the cardiopulmonary training. For patients with reduced endurance and respiratory dysfunction, we introduce diaphragmatic breathing techniques, deep breathing exercises, chest expansion exercises, strengthening of neck, shoulder, and trunk muscles also, which will improve their respiratory efficiency and endurance. So these are all the management and management of physiotherapy in Parkinson's disease. As we conclude today's session, I would like to leave you with one important message. Parkinson's disease may be progressive, but disability does not have to progress at the same pace. While pharmacological management plays a crucial role in controlling symptoms, physiotherapy plays an equally powerful role in preserving independence, mobility, confidence, and quality of life. So our focus as physiotherapists is not merely on treating rigidity, bradykinesia, or postural instability, but on restoring function, preventing complications, and empowering patients to move better and live better. Exercise is not just an adjunct therapy in Parkinson's disease. It is also medicine. Early intervention, task-specific training, balanced rehabilitation, gait re-education, strength training, cueing strategies, and patient education can significantly delay the functional decline. Most importantly, Parkinson's management requires a multidisciplinary approach. At VIAMS, we hear the physicians, physiotherapists, speech therapists, naturopathist, caregivers, and most importantly, the patient, all working together as one team. To everyone who is attending today, I encourage you to intervene early, assess the function regularly, individualize rehabilitation programs, and motivate your patients consistently. And to the patients and caregivers who may be listening, movement is hope. Stay active, stay consistent, and never underestimate the power of guided rehabilitation. Let us move from symptom control to functional optimization. Let us move from limitation to participation. Let us move from fear of progression to confidence in management. Thank you, Team VIAMS, for giving me this opportunity, and to the technical team for their support. Most importantly, thanking you all the participants for your time and engagement. It was a pleasure sharing this session with you. Let us continue to work together to improve the lives of people living with Parkinson's disease. Thank you.
Thank you, doctor. Neurological conditions also affect emotional stability, motivation, cognition, and coping ability. Psychological resilience plays a crucial role in long-term rehabilitation success. To speak about importance of psychological support and mind-body integration in neurological recovery, I invite Dr. Anup CD, our clinical psychologist, to this virtual stage. Over to you, sir.
Thank you. Good evening, everyone. I'm Anup CD, part of VIAMS multidisciplinary team for helping the people with people for neurorehabilitation. Today, we are going to talk about recovery after brain illness or injury, but not only physical recovery, because we can see that most of the people are thinking physical recovery is very important, but we need to focus on we need to understand how the brain, emotions, behavior, or confidence and family support all work together in part of healing. Neurorehabilitation is not only physical therapy, it is building the person's life. Next, we are talking about who need neurorehabilitation. Neurorehabilitation help people who had stroke, head injury, brain surgery. Parkinson's recovery means walking again or moving the hand again. But patients often struggle more with thinking, mood, anger, fear, or confidence than with movement. That's why mental health care become essential. Yeah, next we are talking about what is neurorehabilitation. Recovery is not just about muscles, it includes emotions, behavior, motivation, and independence in daily life. The goal is not only survival, it is returning to life. Eating, talking, making decisions, relationship, and self respect are all part of rehabilitation. When we move into the next slide, brain control everything. Next slide. Yeah. Next. Yeah. Last slide. Okay, I will tell. Brain controls everything. Brain controls thinking, emotions, personality, and motivation. When the brain injured, the person physically may look physically okay, but behave differently. If mental health is ignored, as we know, recovery slows down, participation with the therapy uh, reduces, and family stress increases. So, treating the brain means treating the body and mind. Why brain recovery needs care? As we know, the patient is not only relearning the movement, the brain relearning the life. For recovery, brain needs stimulation, emotional safety, repetition, and encouragement. Without this, the brain stops trying for improvement. Rehabilitation is like teaching the brain to find new pathways. As we know, we can check professionals involved. Neurorehabilitation, as we already told, it's a multidisciplinary teamwork. Doctors treat medical condition, physiotherapists train movement, mental health professionals help thinking, behavior, emotions, and adjustment. Each professionals repair a different part of recovery. When we are talking about mental health professionals, neuropsychologists understand how brain areas affect behavior. Psychiatrists provide medication when mood or behavior change severely. Psychologists like me and counselors help emotional adjustment and coping. Social workers support with family and social integration. Together, they treat the person, not the disease. We are focusing on the person. Yeah, next we are moving to removing stigma. Seeking mental health help does not mean a person is mad. It means we are treating the most important organ, the brain, just like heart, kidney treatment. Brain care is also medical care. Main roles in recovery. Mental health professionals help in three major areas: improving thinking capacity, supporting emotions, and managing behaviors. All three directly affect physical recovery. When we are moving to the cognitive assessment, we check memory, attention, decision making, and emotional control. For example, repeating questions, unsafe decisions, confusion with money, or forgetting instructions. Assessment help us understand what the brain can do and where the support is needed. Also, improving brain power. We train attention, memory strategies, planning, and problem solving skills. Sometimes we restore skills, sometimes we teach new methods like reminders and routines. The goal is independence, not perfection. Next one, emotional support. After brain injury, it is to feel sadness, anger, frustration, or hopelessness. This is not weakness. It is brain and life adjustment. We teach coping skills, stress management, and acceptance so the patient can continue rehabilitation. and also behavior changes. Patient may show sudden anger, crying, low motivation, or social withdrawal. Families often think the person is being stubborn, but many of these changes caused by brain injury, not attitude. We identify the triggers and teach control strategies. Accepting life changes. Many patients say, I'm not the same person anymore. Rehabilitation also means rebuilding identity and confidence. We help the patient find measuring their new abilities, not only compare with the past. When we are talking about helping families, family also need training. Too much help reduces recovery. Most of the families are helping the client too much. Too little help also become unsafe. We need teach the family correct level of support, communication, and motivation. Next, we are talking about invisible disability. Sometimes the patient looks normal physically, but thinking or behavior has changed. This is called invisible disability. Not seeing the injury outside doesn't mean the brain is healed. Next slide. Support versus overprotection. Like teaching a child to walk. If you always carry the child, it will stop learning how to walk. If we leave it alone, it will be dangerous. They will fall down. Correct support help the brain learn again. And also role at different stages. When we are talking about the 3 stages. In hospital, we will do the fear, reduce the fear and shock. In rehabilitation, train and manage behavior. At home, adjust to social and work life. Recovery continues long after discharge. It is not a one stage, it is a continuous stage. Next, we are talking about some golden truth of brain and rehabilitation. Brain can change. The brain can create new pathways. This is called neuroplasticity. But it requires time, repetition, and practice. Improvement is gradual, not sudden. Next truth, mood is fuel. Emotional health directly affect physical recovery. When a patient is depressed, the brain stops trying. Treating mood improves walking, speech, and participation for therapy. And also the small wins. Small win means 5 steps today may be a huge success. If the patient previously walked 5 kilometers, recovery is measured only forward, not backward. And also, next truth, caregiver care. If the caregiver is exhausted, recovery becomes harder. Self-care for family is also an important part of treatment. Another one, connection. Feeling respected and loved is the biological signal for healing. Human connection accelerate recovery. Next one, the important thing for families. Recovery improves with daily practice only, and also emotional support and hope. It slows with overprotection. When we are giving overprotection and ignoring the client's emotion and stopping therapy early, it will slow down. The final message, neurorehabilitation is not only fixing body part. It helps brain learning life again, physically, emotionally, and socially. With right support, improvement continues far beyond what we expect first. And also, I'm appreciating the team VIAMS. They are doing a wonderful job. I'm very happy to be the part of the team. Thank you for giving this opportunity. Thank you, VIAMS.
Thank you, Doctor, for highlighting such an essential dimension for of rehabilitation. Mind-body practices such as yoga and breath regulation serve as powerful bridges between physical therapy and mental well-being. They enhance flexibility, balance, autonomic stability, and inner calm, all of which support neurological recovery. To share her expertise on integration yoga and naturopathic principles into neurorehabilitation, I invite Dr. Aruna KP. Ma'am, over to you.
Good evening, everyone. Today, I would like to discuss the role of yoga in neurorehabilitation, not merely as an exercise practice, but as a scientifically supported integrative therapy that addresses movement, breath, and mental well being together. When we talk about neurological neurorehabilitation, we oftenly focus on medicines and therapies. But today, I would like to explore how yoga can become a gentle yet powerful supported system for patients undergoing neurological recovery. So, let us look at this in detail. One of the biggest challenges patients face in neurological condition is regaining control over their own movement. Improvement in motor control, balance, and flexibility in conditions such as stroke, Parkinsonism, peripheral neuropathy, or multiple sclerosis, patients commonly experience muscle stiffness, weakness, impaired balance, and reduced coordination. These physical challenges can affect daily activity such as walking, climbing stairs, or even maintaining their postures. So, over time, reduced movement may also lead to further stiffness, fatigue, and loss of confidence. So, this is where gentle and careful modified yogasana can play a supportive role. So, the focus here is not on difficult poses or flexibility, it is on safety, stability, and gradual improvement. For example, supported standing practices can help to improve their postures and weight distributions. Chair assisted balancing exercises provides a safe way to train stability and reduces fall risk. So, gentle seated or supine movements can help to maintain their joint mobility and reduces muscle stiffness in patients with limited strength. So, next is the pranayama. In neurorehabilitation, we oftenly focus on muscles, movement, and strength. But one of the most powerful tools we have is something much simpler, the breath. Pranayama or therapeutic breathing technique plays a crucial role in neurological recovery because it directly influences the nervous system. Many neurological conditions are associated not only with movement problem but also with anxiety, sleep disturbances, fatigue, and autonomic imbalance. So, slow, controlled breathing increases your parasympathetic activity, improves your vagal tone, and reduces stress response. So, some useful techniques includes diaphragmatic breathing, Nadishodhana pranayama, and Brahmari pranayama. So, first one is diaphragmatic breathing. So, patients are trained to breathe slowly using their diaphragm rather than accessory muscles. So, this reduces respiratory effort, lowers your heart rate, and induces relaxation. It is particularly helpful in anxiety-prone patients or those who with chronic stress. Next one is Nadishodhana pranayama. So, it is also called alternate nostril breathing. This technique provides autonomic balance and improves your attention. So researchers suggest that it can enhance your heart rate variability, indicates better vagal tone. And third one is Brahmari Pranayama. It is also called humming deep breath. So this humming sound stimulates your vagal pathway and reduces your mental agitation. It is especially useful in patients with insomnia, anxiety, or emotional instability. So in stroke rehabilitation, controlled breathing can also improve trunk stability and enhances your coordination between respiration and movement. So next one is cognitive and emotional benefits. Neurological disorder frequently coexist with depression, anxiety, and reduced attention span. So meditation and structural attention practice in yoga can help to improve your cognitive clarity. For example, guided mindful meditation. So it improves your sustained attention and emotional regulation. Second one is Trataka, steady gazing practice. It may enhance your concentration and visual focus in selected patients. Next one, simple body relaxation technique. This reduces your stress perception. So next one is sleep and quality of life. Sleep disturbances is highly prevalent in neurological condition. Even 10 to 15 minutes of evening breathing practices such as slow diaphragmatic breathing combined with guided relaxation can improve your sleep onset, reduces nocturnal anxiety, and enhances overall sleep quality. So, when we talk about yoga in neurological patients, one very important principle we must always remember is this: yoga should never be one size, it is fit for all. So, every neurological condition is different, every patient is different, and even the same patient can be a different stage of recovery. So, yoga in neurorehabilitation must always be individualized. So, before designing a yogic program, we carefully assess several important factors like first, the stage of disease. Is the patient is in early recovery phase or it is an advanced stage, or is the condition is progressive or stable? So the goal of therapy will varies accordingly. Second one, we evaluate muscle strength. So some patients have weakness on one side. Some may have generalized deconditioning due to prolonged illness. So the intensity and type of asana must match their physical capacity. Third one, we evaluate the level of rigidity. So in conditions like stroke or multiple sclerosis, increased muscle tone can restrict movement. So in Parkinson's disease, rigidity may limit your flexibility. So we choose gentle, slow supportive movement rather than forceful stretching. So next comes balance and fall risk. This is extremely important. If a patient has poor balance or history of fall, standing postures may not be safe initially. For example, a patient with high fall risk should practice only one-sided or supine postures, such as modified Tadasana in seated position, generally spinal movement, or supported breathing exercises. So, safety always comes before progression. We also evaluate cognitive status. So, some patients may have memory issues or reduced attention span or difficulty to follow the instructions. For example, advanced Parkinson's patients may require caretaker support for correct their postures or even for maintaining balance during practice. So this is why supervision by trained professional is essential. So When guided by trained professionals who understand both neurology and yogic principles, the practice became safe, structured, progressive, and truly therapeutic. So at VIAMS, our integrated team ensures that yoga is coordinated with physiotherapy, medical management, and psychological support so that each patient receives a customized plan designed specifically for their condition and capacity. So, because in neurorehabilitation, personalization is not optional, it is essential. Finally, yoga is not a magical cure that reverses neurological damage. However, when practicing consistently and scientifically, it has specific potential to improve your motor function, autonomic stability, emotional resilience, sleep quality, and overall quality of your life. So, in neurorehabilitation, our goal is not only disease management, but restoration of dignity, independence, and well being. So, in that journey, yoga can be a powerful tool. So, next, so far we have explored how yoga supports movement, breath, emotional balance, and sleep. But rehabilitation does not stop with what we do on the mat. It also depends on what we nourish our body with every single day. And that brings us to another equally important pillar of neurorehabilitation, that is dietetics. So let us look at few important components. First one is omega-3 rich food. So omega-3 rich food provides essential fatty acid, that is EPA and DHA, that supports your brain structure, neurotransmission, and anti-inflammatory pathway. So evidence shows that adequate omega-3 intake improves your neural membrane fluidity, reduces your neuroinflammation, and support cognition and mood. So best source includes fatty fishes like salmon and plant sources like flaxseed, chia seed, walnut, etc. So regular intake is associated with better cognitive function and supportive benefits in neurodegenerative conditions as a part of balanced diet. Next one is high fiber diet and hydration. So constipation is extremely common in Parkinson's disease and many other neurological conditions. As discussed earlier, sometimes it even appears year before motor symptoms. So high fiber rich food and adequate hydration are essential for your brain and nervous system health. So fiber-rich food support your gut health, which directly influence your gut-brain axis and help to reduce inflammation and improves your mood and cognition. And proper hydration maintains your cerebral blood flow, support your nutrient delivery to the brain, and prevent fatigue and confusion. So next one is green tea. Green tea contains bioactive polyphenol, mainly EGCG, which has strong antioxidant and inflammatory effects. So experimental and human observation study shows that EGCG reduces your oxidative stress and inhibit neuroinflammation and protect your neurons by modulating mitochondrial function. So regular green tea consumption has become associated with better cognitive performances and lowers risk of neurodegenerative conditions like Alzheimer's disease, Parkinson's disease, and supporting its role as safe, evidence-based diet for your brain. Next one is nuts and seeds. So nuts and seeds are excellent source of magnesium, healthy fat, antioxidants, and vitamin B, all of which are essential for your brain and nervous health. So they supports neurotransmitter function, reduces your oxidative stress, and help to calm the nervous system. So next one is antioxidant-rich food. Antioxidant-rich food plays a crucial role in neurorehabilitation by protecting your brain and nerve cell from oxidative stress, which is commonly increased in neurological conditions such as stroke, Parkinson's disease, traumatic brain injury, and neurodegenerative disorder. So next one is magnesium-rich food. Magnesium-rich food plays an important role in brain and nervous system health. Magnesium helps to regulate your nerve signal transmission, support your neurotransmitter balance, and calms overall nerve activity. So adequate magnesium intake help to reduce your stress, improves your sleep quality, and decrease muscle tension. So all of which are important during neurorehabilitation. So main sources of magnesium are nuts, seeds, whole grain, green leafy veggies, etc. Next one is blueberry. So blueberries are rich in anthocyanins and polyphenols. They are powerful antioxidants that help to reduce your oxidative stress and neuroinflammation. So evidences from human and animal studies shows regular blueberry intake associated with better memory, learning, and cognitive performances, and may help to delay age-related cognitive problems like Alzheimer's disease. Next one is vitamin B complex. So vitamin B complex, especially B1, B6, and B12, plays a vital role in nerve health, neurotransmission, transmitter production, and your myelin sheath formation. So adequate intake help to lowers your homocysteine level, which are linked to cognitive delay and stroke risk. So vitamin B rich foods are green leafy vegetables, nut, almonds, etc. So next one is choline. Choline is essential nutrient for your brain and nervous function. So it helps to produce, it helps to help the production of acetylcholine, a key neurotransmitter for memory, learning, and muscle control. So adequate choline intake may improve your cognitive function, support your liver and nerve health. So choline-rich foods are egg, fish, legumes, and nuts. Next one is resveratrol. So resveratrol is a natural polyphenol found in grapes, berries, and that protect your brain cell by reducing oxidative stress. And it also improves your mitochondrial function. So it may help to slow your neuronal damage and support your brain health in conditions such as Alzheimer's disease, Parkinson's disease, stroke, etc. So each of these nutrients plays a small but powerful role.
Hello.
So reducing inflammation,
Hello.
support nerve signaling, and stabilize your mood, and also improves your gut health and strengthens your muscles. And when these dietary choices are practiced consistently, day after day, they became an active part of your neurorehabilitation process itself. So, which brings us to an important realization. that neurorehabilitation does not happen only inside the therapy room. It continues at home through every meal, every habit, every conscious choice. So, in neurorehabilitation, every therapy matters, and nutrition is one of the most powerful therapy we practiced every single days. By saying this, I'm concluding. Thank you.
Thank you, doctor. And then next. Communication is central to human dignity and independence. Many neurological patients struggle with speech clarity, voice control, swallowing, and expression. Addressing these challenges is essential for restoring social participation and quality of life. To elaborate on the role of speech and language therapy in our integrated model, I warmly welcome MS Dilna Sultana, the speech language therapist.
Is the role of neurorehabilitation in speech therapy? So, speech therapy in neurorehabilitation is essential for restoring communication, cognitive, and swallowing functions after brain injury, stroke, or neurological disease. By leveraging neuroplasticity through tailored exercises, therapists help patients regain speech clarity, language comprehension, and safe, comfortable swallowing. Early intervention prevents complications like malnutrition and improves overall quality of life. Now we will discuss about the key aspects of speech therapy neurorehabilitation. So in swallowing disorders, a therapist evaluate and treat swallowing dysfunction to prevent aspiration pneumonia, which is a critical safety concern. The next one is speech and communication disorders. In this, there are conditions like aphasia, dysarthria, and apraxia. Aphasia means treating impairment in language, writing, reading, and understanding. Whereas in dysarthria, addressing slurred or weak speech by strengthening mouth, tongue, and throat muscles. And in apraxia, retraining the brain to muscle coordination for speech. The next one is cognitive communication skills. In this, rehabilitation of memory, organization, problem solving, and attention to improve functional communication in daily life are being addressed. The next one is social communication, which is pragmatics. In this, a speech therapist will train patients to manage social skills and turn taking and conversation flow. Then the next one is augmentative and alternative communication. This is an integrating tool like apps or whiteboards for patients with severe impairments. And the next one is neuroplasticity promotion. In this, the therapist will utilize repetitive specialized tasks to encourage healthy brain areas to take over impaired function. What is Parkinson's disease in speech therapy? So it is defined as a progressive neurodegenerative disorder of the central nervous system that causes hypokinetic dysarthria, a motor speech disorder characterized by reduced vocal loudness, monotone pitch, imprecise articulation, and breathy voice quality due to muscular rigidity and reduced dopamine. Now we will discuss about the key aspects in speech therapy for Parkinson's disease. The one is hypokinetic dysarthria, which is the primary speech impairment caused by muscle rigidity and bradykinesia, which is slowness, which lead to mumbled, soft, or rapid speech. The next one is voice and communication. Therapy will focus on treating reduced vocal intensity, hoarseness, and monotone speech. The next one is swallowing disorder, which is dysphagia. The speech language pathologists address issues with automatic swallowing, saliva management, which is drooling, and safe swallowing techniques. Then the next one is facial expression. In this, the therapist will address the masked face for a reduced facial expression to improve the non-verbal communication. And the next one is cognitive communication. The therapist will address cognitive decline that may affect word finding and conversation. Now we will discuss about the management techniques for Parkinson's disease in speech therapy. Speech therapy for Parkinson's disease focuses on increasing vocal volume, improving articulation, and managing swallowing difficulties through intensive cue-based techniques. Key approaches include LSVT loud for loudness, speak out for intentional voice production, and respiratory muscle training. Daily practice and environmental modifications are essential for sustained improvements. So, we'll discuss about the key speech therapy techniques and programs. Here comes the LSVT loud, which is Lee Silverman voice treatment. This evidence-based program focuses on speaking loud to recalibrate a patient's perception of volume, and it aims to improve voice intensity, articulation, and vocal cord function. Then the next one is Speak Out and Speak Up, a program that converts speech from an automatic to an intentional act. It utilizes exercises to maintain a strong voice, including structured daily practice and therapy sessions to prevent voice decline. Then the next one is expiratory muscle strength training. And this a device-driven technique that uses a small handheld resistance tool to strengthen the muscles involved in breathing and coughing, which improves loudness and voice projection. Then the next one is articulation training. For this, exercises to combat slurred speech by encouraging over-articulating or exaggerating the pronunciation of consonants. Then the next one is pitch range exercises. Practicing glides from low to high pitches to counteract the monotone voice, which is monopitch, often associated with Parkinson's. Now we will discuss about the practical communication strategies. In this, the one is think loud, which means consistently focuses on using a louder voice than feels natural. Then the next one is pause and breath. Take frequent breaths between short phrases to improve loudness and control. The next one is use cues. Here we utilize visual aids such as apps like Speech Up or a mirror to provide feedback on volume and facial expressions. Then the next one is environmental control. We'll minimize background noise like turning off the TV and sit face to face to improve the communication. Then the next one is vocal rest. Schedule rest periods to manage vocal fatigue for the patient. Now we will discuss about the swallowing management or dysphagia management. Here comes a technique called chin tech technique, which is often used to prevent choking. Then the next one is small bites or sips. Eating slowly and reducing distractions during meals and ensuring small, well-chewed bites for the patient. Then the next one is postural adjustment. Maintain the posture of patient in an upright posture during and after the meals for half an hour. The other techniques include oromotor massage, ice cube massage, thermal stimulation, Z vibe, breathing and relaxation techniques, and working on vegetative skills.
So I'm moving to the conclusion part of this webinar. So a case flow, how multidisciplinary outcomes helps these types of neuro rehabilitation. So Parkinson's disease or any chronic disease is not simply a motor disorder. It affects multiple neurological systems like movement, speech, autonomic regulation, cognition, and emotional stability. So when we treat these domains separately, outcomes plateau. Integrated neurorehabilitation changes the trajectory. So why integration? Our goal is not temporary symptom control. It's structured stage-specific recovery. Integration allows each speciality to contribute toward a unified neuroplastic objective. So this is a case, a 58, this is a moderate stage Parkinson patient having bradykinesia, rigidity, low voice intensity, constipation, and poor sleep. So functional independence is declining. This is where multidisciplinary workflow becomes very critical. So assessment must be comprehensive. Motor scales alone are insufficient. We evaluate gait, balance, swallow safety, autonomic symptoms, psychological state, and nutrition. Precision begins with the depth of assessment. After assessment, we define the stage and functional priorities. Goal must be measurable, improved stride length, better vocal intensity, regulated bowel frequency, improved sleep metrics will be there. So weekly interdisciplinary reviews maintain alignment. So the Ayurveda prepares the physiological terrain by correcting Agni, reducing Ama, pacifying Vada, systemic stability improves, and Panchakarma enhances readiness for rehabilitative training. Physiotherapy drives neuroplasticity through repetition, cue-based gait training, balanced retraining, and extensor strengthening. So we recondition the motor circuits and restore functional independence. Speech and swallowing dysfunction significantly improve the quality of life. So ASLP improves vocal amplitude, articulation clarity, and airway protection, directly reducing the morbidity. Neurological disorders can carry a psychological burden. So structured breathing, relaxation practices, and counseling reduces sympathetic overactivity, improves sleep, and increase adherence. So nutrition optimization reduces inflammation, supports neurotransmitter balance, and improves gut function. Diet is not supplementary, it is foundational. The workflow is structured assessment, multidisciplinary case conference, integration plan, parallel therapy execution, and continuous review. Coordination is the key differentiator. Outcomes must be measurable. We track motor score prediction, improved gait velocity, better sleep quality, improved bowel function, enhanced PDQ. That means PDQ means Parkinson's Disease Quality Scale, 39 scores, and UPDRS is also unique Parkinson's Disease Rating Scale is also there, and reduced caregiver burden. So the future model. So the future of neurorehabilitation lies in coordinated intelligence. So when Ayurveda prepares the body, physiotherapy retains the movement, ASLP restores communication, and mind-body stabilizes autonomy, outcomes accelerate. This is not alternative care. This is evolved, future-ready neurological medicine. So, as a conclusion of this today's webinar, integrated neurorehabilitation represents a structured, system-based evolution in neurological care. By synchronizing Ayurveda and Panchakarma with physiotherapy, ASLP, psychology, yoga, and dietetics, we move beyond isolated system management toward coordinated functional restoration. The VIAMS integrated protocol demonstrates that When multidisciplinary teams operate through a unified workflow, when measurable goals and continuous review, motor recovery improves, non-motor symptoms stabilizes, and quality of life meaningfully advances. So integration is not parallel therapy. It is precision and collaboration. So the major takeaways today's webinar are: Parkinson's disease requires multi-system stage-specific intervention, not fragmented care. Panchakarma and systemic correction enhance physiological readiness for rehabilitation. Movement, re-education, and speech therapy drive neuroplastic functional gains. Psychological, autonomic, and nutritional optimization are critical outcome determinants. Structured, multidisciplinary workflow improves measurable motor, non-motor, and caregiver outcomes. Neurorehabilitation reaches its full potential not when disciplines work harder, but when they work together with precision. Thank you very much. So we are, as the time is pressing, we are moving to the discussion. So you can unmute your mic and ask your questions. We are ready to answer.
ഹലോ
Yeah.
ഞാൻ ചെന്നൈയിൽ നിന്നാണേ.
Yes, ma'am. പറയൂ.
എൻ്റെ ഹസ്ബൻഡ് അച്യുതൻ നായരാണ്. നമ്മൾ അയച്ചിട്ടുണ്ടായിരുന്നു ഇന്ന് രാവിലെ, എല്ലാം അവരുടെ റിപ്പോർട്ടൊക്കെ അയച്ചിട്ടുണ്ടായിരുന്നു.
Okay.
ഓക്കെ. നടക്കാൻ കുറച്ച് ബുദ്ധിമുട്ടുണ്ട് ഇപ്പോൾ. അതാണ് കാലില് കുറച്ചൊരു അൾസർ മാതിരി വന്നിട്ടുണ്ട്. അതിപ്പോ കുറച്ച് വൂണ്ട് ക്ലിയർ ആയിക്കൊണ്ടിരിക്കുന്നുണ്ട്.
ടോസിലാണോ?
ക്ലോസ്, ഇപ്പൊ ക്ലോസ്ഡ് ആണ്. അത് ക്ലോസ് ചെയ്ത് വെച്ചിരിക്കുകയാണ്. കാലിന്റെ ടോസിലല്ല, ഹീൽ കംപ്രഷൻ അൾസർ ആണ്.
ഹീലിലാണ്. ഓക്കെ. അപ്പൊ അദ്ദേഹത്തിന് ബാലൻസിന്റെ പ്രോബ്ലം മോർ ടു ബാക്ക് സൈഡ് ആണോ നടക്കുമ്പോ?
ഇല്ല, പണ്ട് കുറെ വീഴുമായിരുന്നു ഈ സെന്റോപ്പ. ഇപ്പൊ സെന്റോപ്പയുടെ ഡോസ് കുറച്ച് കമ്മിയാക്കിയിട്ടുണ്ട്. മോർണിംഗ് ഹാഫും നൈറ്റ് ഹാഫ് ആണ് കൊടുക്കുന്നത്. ഉച്ചയ്ക്ക് കപ്പിക ചൂർണം കൊടുക്കുന്നുണ്ട്.
So you had sent all the reports?
Yeah, I already sent the report today.
Okay. So our healthcare advisor will review it, and most probably tomorrow itself we will schedule a online consultation.
Okay, doctor. Thank you, doctor.
Thank you.
Doctor. What time you will consult? What time?
Online consultation will be afternoon from 3 to 7 p.m. So in between
3 to 7, maybe 3 o'clock is going for physiotherapy.
So after that, so 4:30 is also fine. So I think any of our healthcare advisors.
6 o'clock after 6.
Yeah, after 6 is also fine.
Okay, then. Okay, then I will call you then. Okay, the same number only, no?
Yes.
Same number. Okay, then. Thank you, doctor. Thank you.
Anybody else have any doubts? Any questions?
How effective is MyDopa? MyDopa, your product is for Parkinson's disease.
Yes, Pankaj Kumar. MyDopa is for it's a herbal health supplement for Parkinson's disease. It contains natural levodopa. Did you already tried it?
Yes, sir. I have started taking it.
Oh, okay.
And what other things I can take that I want to know?
See, now you purchased only MyDopa.
Yes.
Okay, so if you like to have a detailed consultation, contact our healthcare advisor. They will help you to schedule a consultation, and after going to your reports, I will advise you what all rest of the medicines is needed for you. Is that fine?
Yes.
You had okay. Thank you very much. Anybody else have any questions? Please unmute your mic or just raise your hands. You can contact over the 2 WhatsApp numbers showing in the screen. If you have any concerns, you can talk with your healthcare advisors. Okay, Nandan, I think we can conclude. We don't have any more questions, I think so. Thank you. Thank you very much for joining today's webinar. Survey Sandhu Niramaya. Let all be healthy. Good night. Thank you.